Hello and good afternoon. Welcome, Professor Gabel. You have lost much of your weight. You're dieting. I'm going to talk about Hydatid disease, one of the important endemic diseases in our country. And especially, I'm going to focus on the role of the PAIR technique. What is PAIR technique and what's its role? Of course, all of us know about the life cycle of the Echinococcus granulosus, the parasite that is responsible for the disease of what's called Hydatid disease. I'm not going to mention its life cycle. It's one of the zoonoses. But I'm going to remind you of the microscopic anatomy. This is very important to know what you are going to introduce your needle in. This is the microscopic anatomy of the Hydatid cyst here. Pointer. لا معي pointer مش pointer هنا. We have two parts. The cyst contains two parts, part related to the host and part related to the parasite itself. This is the laminated layer around the germinative layer. The germinative layer is the one we are aiming at destruction when we are going to do the PAIR technique. And from this germinative layer arises the broad capsules containing the protoscoloces, which will be the head of the adult parasite. All these parts are related to the parasite, and outside this is a tough capsule formed of fibrous tissue formed by the host itself, and outside it is the parenchyma, a normal parenchyma, taking care that this microscopic anatomy is present in all parenchymatous tissue involved by the Hydatid disease or the Echinococcus. It may involve the brain, it may involve the testicle, the mesentery, the spleen, the lymph nodes, anywhere. They can be found anywhere. Hydatid cyst grows at a rate of about 0.3 centimeter per year. The cyst is filled with fluid under pressure, and this gives it the spherical appearance, and this is very important for its growth. It contains protoscoloces, the Hydatid sand, what we call the Hydatid sand, or granula, giving the parasite the species name granulosus. And hepatic Hydatid cyst may be solitary or multiple, and mostly in the liver they involve the right lobe, but it can also involve the left lobe. I'm going to show you the Hydatid sand, the anatomy of the Hydatid sand. This is a gross picture of one of the cysts that was removed at surgery. Sonographic classification, for many years, many classifications have been proposed, but finally in 2003 the WHO approved this classification. It involves number one, they are not stages of the disease, they are simply types, sonographic appearance of the Hydatid cyst. Number one, the first one is a simple cyst, a simple cystic lesion of the mostly of the liver. This is the first one, a cystic lesion. Simple cyst may involve any organ, but we are going to talk now about the liver mainly. Without a definite wall, this is the CL. And next we have the cystic echinococcosis with large one, like the previous one, but with a cyst wall, and it is larger in size. This is the next one. I'm going to move in that way. This is the next type. And next we have the CE2 type, the cystic echinococcosis type 2, medium-sized multivesicular Hydatid cyst with numerous daughter cysts, like that type and that one. And we have also the CE3 type, a large Hydatid cyst with detached inner membrane. Germinative membrane will be detached, floating inside the cyst, giving it what we call the water lily appearance, or the wheel appearance, or the rosette appearance. All these are names for this germinative layer falling like a sheet folded on itself in the cavity of the capsule. And we have the C3B, which is a mixed pattern, solid and liquid with daughter cyst, and we have the CE4 and C5. C4 and C5, type 4 and type 5, or the sonographic appearance 4 and 5, are considered recently by the WHO as a non-viable Hydatid cyst. These are this type, a pseudotumor type, more and more isoechoic, more and more solid in shape, and the next type with calcification at its wall. Those two types, type 4 and type 5, are considered by the WHO recently as being dead. They are not viable cysts. Okay, what's the treatment of the Hydatid cyst? Anti-helminthic treatment, local interventional ultrasonography using the PAIR technique. I'm going to focus about it now. And the laparoscopic removal have been tried also, and surgical removal by cystectomy have been also tried. All these are lines of treatment of the Hydatid cyst. Now, surgery or PAIR or surgery, this is the conflict. Okay, I'm going to show you in every picture or in every slide some of our archive about the Hydatid cyst, some of the pictures. This is also a Hydatid cyst, a mixed type of Hydatid cyst. Now, since 1986, PER have been proposed as an alternative to surgery since 1986. In 1996, treatment guidelines published by the WHO and the Informal Working Group on Echinococcosis stated that the therapeutic strategy should consider PER. It should consider PER as the first line. Surgery should be reserved for patients with hydatid cyst refractory to PER because of secondary bacterial infection or those with difficult to manage cystobiliary communication, if there is communication or a fistula between the cyst and the biliary system. Surgery is not feasible in the patient is old, general condition is bad, the lesion is post-surgical recurrence, there is multiple organ involvement, or the cyst is near an inoperable site such as a major biliary system or a vascular structure. Now, what are the advantages of PER instead of the surgery? It's a rapid intervention, it's inexpensive, rapid discharge from the hospital on the same day or the next day, no anesthesia, no abdominal scar, and the technique may be repeated. It may be repeated few days after the original one, the first one. Another one with what we call the snowstorm appearance or the hydatid sand inside the hydatid cyst. PER, what's PER? PER is a percutaneous aspiration, injection, and re-aspiration. We percutaneously puncture the cyst, aspirate its content, inject something, and re-aspirate again. This is what we call the PER technique. The PER technique, before the procedure, some workers give these medications. We didn't give it at El Abrashi Center. At our center, we didn't give any of these medications. They may give antihistaminics, muscle relaxants, hydrocortisone, sedatives in order to make the procedure more and more easily. And in order also to avoid the anaphylactic reactions that might occur, I'm going to tell you about the complications of PER. The main complication is the avoidance, is the spillage of the hydatid fluid, which is very allergic in the peritoneal cavity, soiling the peritoneal cavity, and thus may lead to anaphylaxis. Another hydatid cyst. Scolicidal agents usually one of those. Sterile ethanol 95%, hypertonic saline 20-30%, silver nitrate 0.5%, albendazole, iodine 1%, and formalin. We usually at Al Abrashi Center, we use sterile ethanol 95% and iodine 1%, and they didn't give us any complications. Now, the problem with the sterile ethanol, it's very much effective, but its problem is that it's highly inflammatory to the surrounding hepatic tissue and the biliary system. That's its only side effect, but it is highly effective. Hypertonic saline is also effective and have a less inflammable or inflammatory reaction, but hypertonic saline is not aseptic, and so it carries with it the risk of secondary infection of the cyst. Silver nitrate also may be tried. It has the least inflammatory reaction, but silver nitrate is of delayed action. Its action is much delayed. Albendazole, of course, is very physiological. It is the drug used or the chemotherapy used for the treatment of the Echinococcus granulosus, and so it is logic to give it locally inside the cyst, but it's less soluble than the other scolicidal agents, and so it doesn't act as an antihelminthic inside the cyst. Iodine 1% and formalin. Iodine also has less than sterile ethanol, less than inflammatory action on the hepatic tissue and biliary system. Now I remind you again of the microscopic anatomy to talk about the PER technique. This is the technique. First step here, after skin sterilization and localization of the chest of the cyst, and also in deep structures, in deep cysts or near an important structures, you should use a guide. But if the structure of the cyst is superficial, near the cyst and near the surface of the liver, or there is no viable structures around, you can go without. If you are experienced, you can go without a guide. This is the cyst, and you puncture it. You then aspirate the content of the cyst. You puncture it using a Sheba needle, 18 or 16, and then you aspirate the cyst. And then you have this picture. This is the same patient. This is the technique in the same patient. This is a simple cyst, and when you aspirate, the germinative layer here that we talked about before, due to decrease in the intracystic pressure, it separates from the cyst, from the wall of the cyst, and lies inside like that. This is the rosette appearance that we have talked about a little bit before. And then you inject the scolicidal agent. This is the shape. The cyst become hyper-echoic, and then you stay for about 10 to 20 minutes, leave the scolicidal agent inside for 10 to 20 minutes, and then you re-aspirate it again. Take care that you should not. This is a case from our archive. This is at aspiration. The needle is here, and we are going to aspirate this, and this is the cyst after re-aspiration. You notice what? You notice decrease in the size of the cyst, and the cyst become more and more isoechoic, more and more echogenic. Now take care that if a bile, if the fluid aspirated is bile stained, you should think of a biliary fistula and you should call for surgery, and that you inject 60 to 70% of the volume aspirated. If you aspirated about 1 liter or so, you should inject a scolicidal agent of about 70 cc, enough, not all the amount aspirated. You should not inject all the amount aspirated. Okay, this is very important. Another cyst, hydatid cyst with a mixed content. What are the complications of the pair? Spillage of the cyst content and anaphylaxis. This is the main complication. It didn't occur in our series. Cyst hemorrhage, biliary fistula, local recurrence also may occur. These are the main complications of pair, but none of the, I didn't see much of them. For about, in 1 year, we saw about 20 cases, and we didn't see any of these complications in our center. Now, what about the ultrasound changes with PER? The endocyst separates from the pericyst, as I have said. The cyst decreases in size immediately and appears solid. A momentary increase in size can occur after PER lasting for a few hours. This momentary increase in size is not due to the cyst itself, it's not due to the parasite itself. It's just a transudation from the surrounding structure due to the decrease or release of the pressure compressing the surrounding structure. And so there is transudation of fluid inside, and it appears increasing in size. Next, few days later or few hours later, the tissues absorb this fluid and everything goes normal later on. What are the indications of cure? How can you know that the pair you did is successful? Cure depends on the complete destruction of the germinative membrane. The reaspirated fluid showed non-viable cyst. This is why some workers did hematoxin and eosine and light microscopic examination in the scene of the pair technique in order to see if there is viable scoliosis. Then the test failed. Not failed, the patient needs another pair 3 days or 7 days later after that. If not, the pair is repeated again. Now, what's pair PD and DPI? Pair PD is a pair technique associated in large cyst with percutaneous drainage using a pigtail. That's all. And DPI, the pigtail is remained in place to drain these large cysts until its size decreases, and then you infuse the scolicidal agent. The DPI is a double percutaneous aspiration and alcohol injection. It is double because the injected scolicidal agent is left there for a few days, not few minutes, but few days, and then re-aspirated again. This is the DPI. These are all modified techniques of the pair, and they have been tried by many workers. We didn't try it. We only try the original pair technique. Can pair be the first line of therapy of hydatid cysts? Many randomized control trials on different lines in the management of hydatid cysts have been revealed that pair plus albendazole represent the first choice of treatment. Now, it is the first choice. Before talking about laparoscopic removal or before talking about surgery, you should consider first the pair plus albendazole. Albendazole is given for 6 months. Now, what about the future perspectives in this way? In that way, radiofrequency ablation in this field, radiofrequency ablation have been tried on several cases in Italy and in Greece. And they inject alcohol and they introduce the radiofrequency needle and expand it and heat for about 15 minutes in order to sclerose the germinative layer and then remove everything. This is the radiofrequency ablation. It might have a role in the future. Now I'm going to share with you or show you some of the rare cases we have seen. This is a patient that came in the emergency department with dyspnea and tachypnea, and this chest X-ray show an area of consolidation in the right lower lung. And abdominal ultrasonography showed this huge cyst in the liver, and it was a multiple hydatid disease of the lungs and liver. Another case, I remember this patient was a female coming to the outpatient clinic in Asr Al Aini complaining of hemoptysis. Unfortunately, I don't have the chest X-ray. Some of our colleagues took it. The patient was complaining of hemoptysis. Her chest X-ray, plain chest X-ray, showed 2 cysts in the right lower lung zone, and abdominal ultrasonography showed cyst in the liver and cyst in the spleen. This is a case of multiple hydatosis. She was given albendazole and she was treated, followed after that, and she was cured. This is a hydatid disease of the thigh. This is a hydatid disease with a biliary communication. The common bile duct is filled and there is dilated intrahepatic biliary radicle. This is the hydatid cyst removed after surgery, and we see the germinative layer here. And this is an opened hydatid cyst after surgery with the broad capsules inside. Another case with, what's this? A right gastric bubble. It's not a free air under the diaphragm. It takes the shape of a bowel. It has a fluid level. This was a cyst, hydatid cyst in the right lobe of the liver, rupturing under the diaphragm and causing a pleural reaction right here. Hydatid disease of the gallbladder. Not all the mud are gallbladder mud, that's all. Some of them may be hydatid material. Okay, thank you.
Thank you, Professor Amani, for the nice presentation. I actually have a question about